Thank you so much. I'll just try to finish in time. It's not that I'm telling you something new. Phacoemulsification or cataract surgery for that matter was done even when there were no OVDs. Basically, what is the role of viscoelastics and what things can go wrong if you don't have that OVDs? First is I showed you about when there was no visco, the surgeries were done under air bubble, and these are the PCRMs which can happen if you don't have the viscoelastic being used. And corneal decompensation is the second thing. If you do not do the surgery properly as the tips has been advised, this can lead to such a corneal decompensation. So basically it comes as a replacement for the air bubble for three things. One is before you do the capsulotomy, second is before you put in the lens, and third is to avoid the complications like the ruptured capsule and the decompensation of the cornea. First, before capsulotomy, second, to protect the corneal endothelium, because if you have a good anterior chamber space, then you don't damage the endothelial cells. And third, before you put in the lens, you need to have a space where the lens can go in and doesn't damage the endothelium. Most of the surgeons do it for this reason, not to mention anything about that. But tell me, are OVDs totally free of side effects? No. You have the intraocular pressure spikes going on, though it is transient. You have the capsular distension syndrome, again, though it's transient. But what about the inflammation? We have had cases of series of endophthalmitis, and the culprit was nothing but the viscoelastics. Contamination is a major issue, and of course, you need to remove when you have put in the viscoelastics. What is modern cataract surgery all about? It's a closed chamber, smallest incision, better fluidics, efficient power delivery, and it should be reproducible. So phaco without viscoelastic, it's possible. Why and what are the advantages? Because the surgical time is less, you don't put in and you don't remove it. Less risk of post-operative IOP spikes. I'll tell you the biggest advantage. You do not take this entire presentation of mine, do not do no ViscoPhaco, but there are few tips which if you can adopt, you can actually improve the surgical technique. This is the one. Continuous irrigation with your left hand, you actually make the fixation of the eye. Patient cannot move because most of us are doing under topical anesthesia. So this continuous irrigation with the bimanual helps you fixate the eye. It protects the endothelium the similar way. Fixation I've already told you. Toric lenses because that becomes the end stage. And the post-operative data shows there is no significant difference between the endothelial cell loss. So it is possible, but not in all cases. Hard cataracts, you have to use visco. Shallow AC, hypermetrop case, you have to. Intumescent because the just rexis goes away. Small pupil, since you have to make 3-4 incisions, you have to use the viscoelastic. Pediatric cataract, we all know, aim for the 3 mm rexis, turns out to be 6 mm. Complications and IOL exchange. But these amounts to just less than 20%. So I'm sure no pharma people are sitting here because they'll be unhappy with listening to this video. The first is that you make a side port with an MVR blade. Again, you made the other side port through an MVR blade. Then you put in a irrigating cannula. It helps you do two things. One is it forms the anterior chamber. Second is it allows you to keep the eye fixated. The patient, howsoever strong it is, howsoever uncooperative, he cannot move the eye. So with this irrigation cannula, you have the formation of the anterior chamber, one, and second, you have the fixation of the eye. Can I just fast forward it a bit? Can you help me, please? Yeah. So after you have done the rexis, just make sure that you hydrate the two side ports so that the anterior chamber is formed, as I'm doing it in this case. Can I do it myself? Then once you have entered with your phaco probe, then it hardly makes any difference whether you have used visco or you have not used visco, because once the nucleus is out, then the chamber itself becomes very deep. So at this point of time, you don't need viscoelastics. You use the bimanual irrigation aspiration, take out the cortex from both the sides. You do the capsular polishing. Now, this hydro, what I was telling you, even if you do not do the no visco technique, there are few things like the irrigation continuously which fixes the eye, and this hydro implantation, take it from me, you start doing it from tomorrow. There is no need of viscoelastic. Hydro implantation is a very good technique, and it takes you to the end of the surgery. Once you have put in the lens in the cartridge, just fill in from both the ends BSS as much as you want, because it's going to leak out. But still put as much as you can from both the ends, and then fold the cartridge and just simply do the hydro implantation. And this is a very simple technique. It goes through even the 2.4 millimeter incision, and that takes you actually to the end of the surgery, because here after you have things to be removed from the eye, and just need to dial, put it inside the bag, and just hydrate the two side ports and the main incision, and you have the surgery coming to an end.
I think we'll wind up with
Yeah.
that, and just
So
give an
just to
opportunity.
summarize,
Can we just give an opportunity to him?
yeah,
for,
you have the less post-op IOP spikes, you have the control and the less surgical time.
Yes, sir.